Edoxaban for the treatment of cancer-associated venous thromboembolism. Personal data, definition, application in medicine, pros and cons, issue, applet, conclusion. Personal data. My name is Angelic Arle Bravo Montes. Teacher, Moscoso Escobar John Fernando. Definition. Venous thromboembolism is a common complication of cancer and its therapy. Thromboembolism is challenging and the risks of recurrent thrombosis and bleeding are higher among patients with cancer than among those without cancer. These two complications are important because they contribute to mortality and morbidity and may interfere with cancer treatment and increase the risk of hospitalization. Continue the video.
Venous thromboembolism, or VTE for short, is a leading cause of death worldwide. In the Western world, someone develops a VTE every 60 seconds. Manifestations of the disease are deep vein thrombosis and pulmonary embolism. The disease process starts, often in one of the large veins of the leg, with the formation of a blood clot. This can be due to vessel wall injuries, a pathological increase in the coagulability of the blood, or circulation deficits such as venous stasis. The resulting blood clot consists mostly of red blood cells, held loosely together by strands of fibrin. There is a considerable risk of such a fragile clot or parts of it breaking away and traveling with the bloodstream through the heart and into the lungs. Here, the clot or fragment of clot eventually blocks a pulmonary artery. The consequence, pulmonary embolism. The affected area of the lung is no longer available for the oxygenation of blood. This life-threatening outcome can be traced back to an inappropriately triggered physiological process, blood coagulation. Various medical conditions are associated with disrupted blood coagulation and therefore an increased risk of VTE. For instance, immobilization heightens the risk of hypercoagulability of the blood and venous stasis. Patients undergoing major orthopedic surgery, such as total hip or knee replacement, have an additional risk of vascular injury.
Application in medicine. The Ocucide VTA cancer trial compared the oral factor XA inhibitor Edoxaban with subcutaneous dalteparin for the treatment of patients with cancer-associated venous thromboembolism. The trial assessed for a composite outcome of recurrent venous thromboembolism or major bleeding, which are the two most prominent complications of these therapies. The objective was to compare these two regimens of at least 6 months and up to 12 months to provide needed guidance on treatment beyond 6 months. Continue the video.
Venous thromboembolism is a common complication of cancer. While subcutaneous low molecular weight heparin is the standard treatment for cancer-associated venous thromboembolism, the role of direct oral anticoagulants is unclear. A randomized open-label non-inferiority study of 1,046 patients with cancer and confirmed venous thromboembolism tested the efficacy of anticoagulant therapy for up to 12 months. One group was treated with subcutaneous low molecular weight heparin for at least 5 days, followed by 60 milligrams of oral Edoxaban once daily. The other group received 200 IU of subcutaneous dalteparin per kilogram once daily for 1 month, followed by 150 IU per kilogram thereafter. The primary outcome, a composite of recurrent venous thromboembolism or major bleeding event during the 12-month follow-up, occurred in 12.8% of the patients receiving Edoxaban, as compared with 13.5% of the patients receiving dalteparin. Statistically, this result demonstrated the non-inferiority of Edoxaban to dalteparin, but did not demonstrate its superiority. Recurrent venous thromboembolism occurred in 7.9% of the patients receiving Edoxaban, as compared with 11.3% of those receiving dalteparin, and major bleeding occurred in 6.9% of the patients receiving Edoxaban, as compared with 4.0% of those receiving dalteparin. The authors conclude that in patients with cancer and venous thromboembolism, oral Edoxaban was non-inferior to subcutaneous dalteparin for preventing the composite outcome of recurrent venous thromboembolism or major bleeding. Edoxaban's lower rate of recurrent thromboembolism was offset by an increased risk of major bleeding. Full trial results are available at nejm.org.
Pros and cons. Pros. The rate of recurrent venous thromboembolism was numerically lower with Edoxaban than with dalteparin, 7.9% and 11.3% respectively. Cons. The rate of major bleeding was significantly higher with Edoxaban than with dalteparin, 6.9% and 4.0% respectively. The frequency of severe major bleeding category 3 or 4 was similar with Edoxaban and dalteparin. Continue the video.
Hello, this is Dr. Carlo Ojeda, emergency physician and founder of Edoxaban.com. This video is about gastrointestinal bleeding. The first thing we need to do is make the differentiation between upper gastrointestinal bleeding and lower gastrointestinal bleeding. If you're vomiting blood, that is called hematemesis. And hematemesis can be due to a Malloy-Weiss tear. If you want to learn more about that specifically, I have a video just on that. But it's usually a result of forceful vomiting that causes a tiny tear at the junction of the stomach and the esophagus. It's usually self-limited, and it heals itself in 2 or 3 days. It's not severe, it happens in young people, and it really doesn't pose any major bad outcomes. But it can also be due to a more deep tear of the esophagus. It can be due to ulcer. It can be due to severe gastritis and upper, like cancer in the stomach and so on. So, for people with other disorders, persistent upper vomiting through the gastrointestinal tract, then patients usually need an endoscopy, a tube down the throat, into esophagus and into the stomach to see the bleeding and perhaps make it stop. Of course, if you're tachycardic, hypotensive, if you have a low blood count, then you're more likely to need a blood transfusion, more aggressive management. If your vitals are normal, you only vomited blood once, you're very likely to go home. If the bleeding is from below, from the rectum, then it can be many different things. First, it could be a massive upper gastrointestinal bleed because blood is cathartic. It makes diarrhea, so the bowels move really fast and the blood still comes out red or maroon colored, as we call it. If this is the case, you probably will have systemic symptoms and it will be treated by admission, IV medications, possible transfusions, and an emergent endoscopy. Bright red blood per rectum without any pain is usually benign disease. It's either an internal hemorrhoid, internal polyp, but usually diverticular disease, especially if you're older. See, most people in the United States have diverticulum, which are tiny pockets in the distal sigmoid colon. And these can bleed from time to time. But if you're older and you have this massive type of lower GI bleed, it probably needs a sigmoidoscopy and something to make the bleeding stop. It can also be due to polyps, AVMs with arteriovenous malformations. It can be due to an external hemorrhoid, but usually the pain from external hemorrhoid is very severe, very sharp, and you can feel a lump in the rectal area when you're palpating. So that covers more of the common causes of gastrointestinal bleeding. If you think you have one of those, I probably already have a video or a link in my website to one of the videos that explains each kind of individual type of bleeding. For example, external hemorrhoids, internal hemorrhoids versus diverticulosis and diverticular bleeds, and so on. I hope you find this useful, and God bless.
Issue update from July 2015 through December 2016, a total of 1050 patients were enrolled at 114 centers in 13 countries, with involved patients with predominantly advanced cancer and acute symptomatic or incidental venous thromboembolism. Continue the video.
What is important to realize is a comparison of two regimens. It's not a comparison only of two drugs, but because the one comes with subcutaneous injection and the other one comes with taking a pill, it really has their own intrinsic qualities. The other unique part of the design was that from a patient perspective, and actually also from an oncologist perspective, if you have that venous thrombosis, there are two things you don't want to happen. One, a recurrence, or a major bleed. And so for this study, we therefore agreed that the primary outcome would be the composite of either the first recurrence or the first major bleeding. So it's a composite outcome of an efficacy and safety. And that's based on what I just mentioned, the fact that from a patient perspective, both are unwanted. Both are a disaster, will interfere with treatment, and if you can eliminate both, that's the purpose. The second element in the study was all the studies that had been done until 6 months. And so what we agreed is actually, listening to the guidelines, is if the physician and the patient wanted to continue the treatment because the cancer was still active, they could actually continue beyond 6 months. The study followed all patients for 12 months. And so our objective was to show that what we have right now, which is the low molecular weight heparin standard, that in terms of that primary outcome, the recurrence or the major bleed, that it will be non-inferior, that these were as good as the standard. And that's what we convincingly showed. So the primary outcome, as they officially call it, is following these patients all the way up to 12 months, and whether they got a bleed or whether they got a recurrence, that was counted as an outcome, and that was 12%, 12%. So completely identical. What we did, in addition to that, is we looked at some sensitivity analysis, which basically is a way to see how robust the outcome is. So we also looked pre-specified at 6 months, and at 6 months, clear non-inferiority. And then finally, the way you can do it is look per protocol. That's to say, everybody that really followed the protocol, which is a kind of a conservative other, and again, very nice non-inferiority. So the overall conclusion is that if you have a venous thromboembolism associated with cancer, and in this population, the great majority of these patients with active cancer were receiving anti-cancer therapy. More than half the patients had metastasis. So we're talking about a really sick population. Providing them with one pill a day would protect them from the primary outcome, bleeding or venous thrombosis, in a very, very identical way to what we have right now in the standard of low molecular weight heparin. The last point what we did is we looked at the severity of the bleeding when they occurred. And that follows a scheme of categories 1, 2, 3, 4. But 3, 4 are really the categories you'd like to avoid. And that was completely identical. 12 patients in each of the arms. So overall, easier to give, as effective, actually slightly more effective, but that's a bonus. And in terms of severe bleeding, identical.
Conclusion. In conclusion, is in this trial involving patients with cancer-associated venous thromboembolism, Edoxaban was non-inferior to dalteparin with respect to the composite outcome of recurrent venous thromboembolism or major flooding. Continue the video.
This is a study in patients that have cancer and develop venous thromboembolism. We've done previously Hoxi VT study, that's in patients with venous thrombosis, and a minority of these patients actually had cancer. In the Hoxi VT cancer, it was 100% patients that had cancer and then developed venous thromboembolism. That actually occurs about 20%, 25% of all patients that are seen with venous thromboembolism have concurrent cancer, so it's not a rare disease. The second problem with that particular condition is it is associated with high risk of recurrence and a high risk of bleeding. But most importantly is these patients have cancer and they want to get rid of their cancer, and venous thrombosis is a nasty complication, so they want to get rid of that. That's why we designed this study. And the last point before I come to the study is the standard of care. The standard of care that is accepted by all the guidelines in North America and in Europe is to give low molecular weight heparin per subcutaneous injection. That has been shown in a number of trials to be the best treatment in terms of efficacy. And so therefore that's the standard. The disadvantage, very obvious, is these usually sick patients with active cancer need to inject themselves for a prolonged period of time. These guidelines say at least 6 months. But if the cancer is still active, actually longer, so it may be 9 months or 12 months. And that's why we designed the Hoxi VT cancer study, because at one end is the low molecular weight heparin is the standard, and the other one in this study was Edoxaban, which is 1 pill a day, oral medication. And so the objective of the study was to compare the standard treatment of low molecular weight heparin injections once a day for as long as it takes, compare it to the oral Edoxaban.
Thank you.